Hello everybody, my name is Shivani Patel and today I will be talking to you about neonatal approach to a cyanotic newborn and classification of cyanotic heart lesions. This is a lecture that we wanted you to review before we do an interactive session for the same. The authors have no conflicts of interest. So what are our learning objectives? The objectives are to create and have a framework for the evaluation of cyanosis or desaturation, understand the confounding factors of cyanosis, identify the broad categories of cyanotic heart defects, and have a framework for categorizing cyanotic congenital heart disease. You have to be able to understand the cardiac anatomy that can present with central cyanosis, and also understand the cardiovascular pathophysiology contributing to the central cyanosis. The other element that we want to introduce for you and help you understand is how to draw a cardiac stick diagram, anatomic connections, blood flow in the appropriate colors, and then identify cardiac pathology as depicted by a stick diagram and basically walk yourself through a cyanotic lesion. So having said that, let's get started with a very broad framework for cyanosis. How are we going to recognize it? How are we going to diagnose it? How are we going to distinguish between peripheral and central cyanosis? How we are going to use our labs and clinical exam and some oxygenation testing to come up with, based on our exam, x-rays, ECGs, and eventually echo, come up with a diagnosis for a cyanotic lesion. So, what is cyanosis? How do you recognize cyanosis? It is essentially a bluish appearance or discoloration of the skin. What are the things that we kind of take for granted? What is the light around you? Are you looking at this baby in the darkish room of a mother-baby room? Or are you in the bright light of a NICU? Or you are called to the peds floor? It could be anywhere, and you have to take into account what your lighting looks like. What is the skin pigmentation? What ethnicity, what race is this baby of, and how that impacts color? And then finally, our own color receptors in our eye and our cortical ability to appreciate cyanosis. Cyanosis is related to desaturated hemoglobin, our oxygen-carrying protein in the red blood cell. If you are severely anemic, it's hard to be cyanotic. But if you're very polycythemic, which neonates tend to be initially, they are more likely to be cyanotic. Cyanosis is classically described as deoxygenated hemoglobin in the arteries below 5 grams per deciliter. And like I said above, and I think I repeated this on the slide, it's hard to be cyanotic when you are severely anemic, and you're more likely to be cyanotic when you are polycythemic. Then when you're diagnosing the desaturation, you have to take into consideration where you're putting your oxygen saturation probe on. So let me find my laser pointer. This is the baby, right arm, left arm, lower extremities. Here's a picture of the heart showing the aortic arch come off. And the patent ductus arteriosus sits between the aorta and the pulmonary artery, coming off after the branch to the right subclavian has come off. So essentially, your right arm is going to give you your preductal saturation, and then everything after that is postductal. Now the left arm, depending on the condition, depending on the arch anatomy, can be, if in case of an aberrant left subclavian artery, can be misinterpreted. So we go with the lower extremity oxygen saturation as our postductal saturation. So you should keep that in mind as you are obtaining the pulse oximeter saturation. So what is the difference between central and peripheral cyanosis? Peripheral cyanosis, as you understand from the word itself, is cyanosis that results only peripherally due to either vasoconstriction, a sluggish blood flow, increased peripheral extraction, so things like shock, sepsis, hypothermia, autonomic changes. And then central cyanosis, three things could be wrong. You could have bad lungs, bad blood, or a bad heart. When you have abnormal lungs, you could have primary lung disease, VQ mismatch, hypoventilation, and there are many reasons for each of those things as you can think about. Abnormal blood, think about methemoglobinemia, where the hemoglobin does not bind blood in all proportions, and so you have a low saturation despite a normal PO2. And then finally, you could have abnormal heart issues. So here is a chart that lists the differential diagnosis for cyanosis. And as you can see, the bad lung, the bad heart, the bad blood are all the different causes that you can see here. They have been differentiated as airway issues, breathing issues, and circulatory issues. And you can pause at this slide and go through this list. I'm not going to list them all, but this is for your knowledge. So whenever you're called to evaluate a baby with cyanosis, you always do a quick glance at what are you walking into? What was the pregnancy like? What was the labor like? What are the newborn risk factors that you're looking at? Is there maternal diabetes, which increases the risk of congenital heart disease? Was there a fetal echo done? Is this hypoglycemia associated with lethargy and hypoventilation? Are there risk factors for infection, premature rupture of membrane, GBS status, chorioamnionitis? So you always take into account what are your surrounding data that you have to help you. The physical exam, um, appropriately done when the baby is warm, quiet, and knowing things like that a baby who's small or large for gestational age is more prone to polycythemia and so more prone to being cyanotic. Looking for any airway issues. We just looked at that long list of possible causes of cyanosis, so making sure that micrognathia, Pierre-Robin syndrome, stridor are not present. Looking at the degree of respiratory distress, tachypnea, retractions, nasal flaring. Is this central hypoventilation? Is there a neurological issue in the background? Is there a concern for a birth trauma, such as an Erb's palsy or a stridulous cry? And then finally, coming down to the cardiac exam, heart rate, pulses, perfusion, brachiofemoral delay, heart sounds, focusing on the second heart sound, whether it's very loud, as you would maybe hear in pulmonary hypertension, or single in single ventricle type lesions, or the presence of a right ventricular heave. Murmurs are typically not very useful for making a diagnosis, but you can hear a harsh ejection murmur characteristic of pulmonary stenosis. The goal of putting up this slide is to just give you a general overview of the things that you will be looking at whenever you have a cyanotic baby. So the next step that you do once you know that this seems to be central cyanosis, so you go looking for associated signs. Is this the lungs? So you're looking for a patient in which the cyanosis is associated with signs of respiratory distress. Is this cardiac? You will have central cyanosis, but without any hemodynamic instability or respiratory distress. Babies are comfortably blue. Is this sepsis? This poor perfusion can also appear as cyanosis. Presence of hypotension, hypothermia, or fever suggests sepsis. Methemoglobinemia, the babies will appear completely well with the exception of cyanosis. You call for a blood gas, and based on your pH, your PCO2, your PO2, and finally the hyperoxygenation test that we'll talk about in a second, you can come up with some sort of a distinct pattern. Is this respiratory? And I need to check my spelling there. Is this respiratory or sepsis related, or is this cardiac related? So a PO2 that is moderate to severely reduced with a low normal or decreased PCO2 with no change on the PO2 with hyperoxygenation with 100% O2 points more towards a cardiac cause of the cyanosis. So what is the hyperoxia test? You measure the PaO2 on 100% oxygen. If it remains less than 100 millimeters of mercury, then this is a strong case for cyanotic congenital heart disease. The shunted blood, the blue blood, cannot participate in gas transfer. The patient remains blue. However, if with 100% oxygen, your PaO2 improves to more than 150, this is more likely to be a pulmonary process related to alveolar recruitment mismatch, VQ mismatch, and severe RDS. When we initially presented these slides a few years ago, we got feedback from some of our neonatologists that overall there has been a de-emphasis on the hyperoxia test. There's a case for false positives due to TAPVR, HLHS, which is total anomalous pulmonary venous return, and a hypoplastic left heart syndrome. There could be false negatives due to intrapulmonary shunts. There's a decreased ventilation in patients treated with hyperoxia, worsening acidosis, increase in PVR in patients with lung disease. Concern for free oxygen, radical injury to the lung and to the brain. And then overall establishing arterial access, which you need for this test, can take longer than expected. So what has our traditional approach been to a baby who we consider to have central cyanosis? Chest x-ray. Assess your pulmonary blood flow. Is it less? Is it more? Is it abnormal? And look at the size and the shape of the heart. We've been taught to look at electrocardiograms, and based on the axis, we can draw some conclusions. And finally, the mnemonics for cyanotic heart disease that we've been learning since med school, the 5 T's and the P, truncus transposition, tricuspid atresia, tetralogy, total anomalous pulmonary venous connection, and finally pulmonary atresia. So if you take the traditional diagnostic route by pulmonary blood flow methodology, you take a chest x-ray for the child and you look, is this oligemic lungs, meaning decreased pulmonary blood flow? Look how dark the lung space is. Or is this increased pulmonary blood flow? Look at how much more blood flow there is to the lung. So that is the traditional approach. Is this oligemic or more blood out to the lungs? Increased pulmonary overcirculation. So with that, once you look at the decreased pulmonary blood flow, then you look at the heart. Do you have a small heart or a big heart? If you have decreased pulmonary blood flow in a small heart, you're looking at the right-sided lesions that are tricuspid atresia, pulmonary atresia, where your right side is kind of missing, and then tetralogy of Fallot, where you can have pulmonary stenosis. And then the example of decreased pulmonary blood flow with a large heart would be something like Epstein's anomaly, where the right atrium is so big that it leads to an enlarged silhouette of the heart on the chest x-ray. And the problem here is there's inadequate pulmonary blood flow. That's why the need for prostaglandins. Then you could have a chest x-ray with normal blood flow, normal size of the heart, that usually ends up being a detransposition because it's the blood makes it to the lungs. It's just the wrong type of blood. The red blood is going to the lungs and the blue blood is going to the body. So the size of the lungs and the heart and the size of the blood volume in the lungs remains the same, but so everything is normal based on chest x-ray, but it's the wrong type of blood. And then you can have increased pulmonary blood flow, which again, you look at whether is there a small heart or a large heart. And a small heart can result if there is a total anomalous pulmonary venous return, which is obstructed, so not enough blood goes through to the left side. And then you can have a large heart that you can see in a single ventricle, truncus, or total anomalous pulmonary venous return. So there's some traditional diagnostic methodology of how to diagnose cyanotic heart disease by pulmonary blood flow. Having shown you all of this, I don't think in today's day and age we diagnose cyanotic heart disease using a chest x-ray. It's a good skill to have, but I don't think it's very relevant today. Um, Problem with the chest x-ray: pulmonary vascularity, somewhat subjective. There could be rotation, there can be distortion, the thymus confuses things, and pulmonary vascularity may fluctuate based on loading conditions, PVR, and SVR. But we also need to pass our boards. And so here are a few known um, key special chest x-rays. Here's a chest x-ray that is classic boot shape. The reason why it looks boot shape is because the usual appearance of the main pulmonary artery in this region is missing. So there's like a almost like a right angle there. And this is classic for tetralogy of Fallot. This baby may have a harsh systolic murmur at the left upper sternal border due to the pulmonary stenosis. And the S2 is really hard to split because the pulmonary component may be missing. Here is another one. This is a classic appearance of what we call egg on string appearance, and this is transposition. And it appears like this because the two blood great vessels, instead of kind of being right and left anteroposterior to each other, they are directly anterior to each other, with the aorta more anterior than the pulmonary artery. And so instead of a wider uh, diameter occupied by the great blood vessels, it's kind of narrow up top and then the heart at the bottom. So typically this baby is very desaturated, typically a single S2. And then here is an example of snowman heart, a total anomalous pulmonary venous return of a supradiaphragmatic type. Basically, there's an accessory chamber where all the pulmonary veins drain to superior to the heart. So if you see these x-rays on your board, you should be able to pass your boards. This is Epstein's anomaly. This is a massive right atrium resulting in a severely enlarged cardiac silhouette. You can see that the right heart extends all the way onto the other side of the right side of the chest. EKG, again, similar to the chest x-ray. I don't think today you are going to make a diagnosis of a cyanotic heart disease based on your EKG, but it is good practice to understand how the EKG reflects what is going on in the chest of the child and how it can help you. So just a little brief review of what the axis of an EKG is. So this is your baby. This is the sinus node, typically around the on the right atrium side. And the signal, the conductive signal, starts from there and goes across through the conduction system towards the apex of the heart, and as it goes to each of the ventricles down below. And you can see they've drawn this quadrant out here, and a normal axis seen here by this purple color is typically between -30 and 90. And then you have right axis deviation, the green one, and you have left axis deviation, and the purple one. So a normal axis where your signal is going like it's supposed to is you will have a positive in lead 1 and positive in lead AVF. If you have a right axis deviation, your right side of the heart is more prominent, you're going to have a negative in lead 1 and a positive in AVF. And then our left or superior axis deviation is your lead 1 could be positive or negative sometimes, but your lead AVF is negative. So with that, knowing that, this is the EKG that you have, and whoops, that is lead 1, it's negative. That is lead AVF, which is positive. And so this is right axis deviation, which can be normal in newborns because the right side of the heart is more prominent. Here's another ECG. Here you can see lead 1 is positive, and here lead AVF is negative. And so this is a superior axis deviation, which is abnormal. Think tricuspid atresia, or even more commonly, AV septal defects. So now that you kind of have gone through your framework, you have come to the conclusion that this is central cyanosis related to a cardiac issue, and you really need to manage this child, consult a cardiologist, get an echo. So you call for, so you're at this point. So what are you going to do? I wanted to sneak in a slide on prostaglandins here. You get an echocardiogram, but prostaglandins can be a lifesaver even before you know what the final diagnosis is. So get IV access, get a dose of prostaglandin in. The initial dose is not standardized, but most will agree that starting prostaglandin E1 at 0.01 microgram per kilo per minute is appropriately effective. One of the things my neonatology colleagues have taught me is that prophylactic intubation is not a thing. So get your prostaglandins in order, get your echocardiogram, and whoops, before I move on to the echocardiogram, remember these side effects of prostaglandins. You have to know this because this will be on the boards. Fever, apnea, flushing, gastric reflux, gastric outlet obstruction, apnea, and a very long-term side effect is hyperostosis of the bones that these arrows are pointing to in this chest x-ray. So now I'm going to move on to the real deal. This is echocardiography. This is how we diagnose cyanotic congenital heart disease. What we have learned so far is how we approached a baby with cyanosis, and now we are going to try and get to the bottom of it. So when you think of echo, you have to think through the cardiac anatomy, and then you have to add along the physiology. I'm going to orient you to something that we will be using consistently through our curriculum series, which is our cardiac stick diagram, or box diagram, sorry. So if you look here, I want you to pay attention to this picture here. This is the right side of the heart, and this is the left side of the heart. You can see the systemic veins, SVs, draining into the right atrium, passing through the tricuspid valve, into the right ventricle, passing through the pulmonary valve, into the main pulmonary artery, branching into the right pulmonary artery and the left pulmonary artery. Now that the blood has made its way through the right side of the heart, it comes back from the lungs with oxygenated blood, comes in through the pulmonary veins into the left atrium, passes through the mitral valve, into the left ventricle, through the aorta, through the aortic valve, into the aorta. And you can see this is a one cardiac output going through the entire right and left side of the heart. What is cardiac anatomy all about? It's all about the plumbing. So you have to find a hole, which is the defect. You have to find the obstruction, and you have to see if there are any abnormal connections. So a defect can sometimes be useful. Sometimes it is the main lesion, but sometimes a defect is useful. Things like an ASD, which is useful for blood to get across from right to left or left to right, depending on what's going on distally. Obstruction. It basically is there an anatomic obstruction where one of the valves is stenosed, or the artery is atretic, or is there high PVR that is preventing, there's high resistance to flow that is preventing blood going out to the lungs, or high SVR that is preventing blood going out to the body. So the obstruction can be both anatomic or resistance to flow. And then abnormal connections is basically lack of mixing, where there are parallel circulations with separate pulmonary and systemic circulations. Essentially, we are talking about transposition there. So here's, I'm just going to introduce you how we draw an intact septum. You can see the space here. That is what we consider a septal defect or a hole. Here is an example of a normal valve entering into a ventricle and a normal semilunar valve. And then here is something that is stenotic. You can see that we've drawn it dark, and then there's a little tiny space across it. And then here, so that's why we call it stenotic. And if you look at these valves here, these are atretic. There's essentially a black line across it that basically is telling us there is no flow across this valve. And this is an example of abnormal connections, where on the right side you have systemic veins bringing in blue blood, going into the right atrium, going into the right ventricle, but instead of going to the pulmonary artery, it's going out to the aorta. And on the opposite side, the left ventricle is going out to the pulmonary artery. So this is detransposition of the great arteries, which with these abnormal connections results in a completely desaturated baby. So, starting off with normal circulation, like we just walked through a complete circulation from the blue side, the right side of the body, all the way to the left side, the red or the oxygenated side of the body. The next step is what happens in the newborn. In the newborn, you have the addition of a patent foramen ovale, which is the opening between the top two chambers of the heart, and you have a patent ductus arteriosus, which is a connection between the aorta and the pulmonary artery. And these two can be a great source of help in patients with congenital heart disease, because they aid in mixing and they help get blood to where it needs to be if there are some issues in the heart. With this in mind, to some typical timelines. In about 4 weeks, the PDA closes, and in about 4 to 8 weeks, the PVR starts dropping. These two things can result in physiologic changes in the blood flow. So the physiology of this will depend on the mixing and the pulmonary and systemic vascular resistances. We have to remember that the degree of cyanosis or desaturation will depend on the amount of systemic venous return that is mixed with the amount of pulmonary venous return, and the obvious roles of the resistances or obstruction and the relative resistances in the lungs and the body. So here is an example. On the left side of the screen, you have a patient with a high PVR. And as you can see, because there is high PVR, not as much blood goes to the branch PAs, but blood follows the path of least resistance across the patent ductus arteriosus and mixes with the red blood to give a cyanosed appearance to the blood that is going out to the body. So as opposed to this patient that has a low PVR, there is not much obstruction to the blood going out to the lungs, and so blood following the path of least resistance goes from the aorta to the pulmonary artery, resulting in a baby that is not cyanosed and has fully oxygenated blood going out to the postductal area. So take into account the importance of high PVR and low PVR. So having learned all the basic stuff so far, thinking about the anatomy and the physiology, we finally come down to what are the different cyanotic heart lesions, how do we classify them, and how do we diagnose them. So this slide, it's a very dense slide. I would like to spend some time on it, walking you through this slide. We'll start at the very beginning, um, encompassing all cyanotic heart lesions. We divide them into two categories. One is a mixing lesion, meaning there is a hole or some form of obstruction that results in mixing of the red and the blue blood, resulting in cyanosis due to desaturated blood going out through the aorta. And then there is a non-mixing lesion. And just to make it clear, transposition is the only non-mixing lesion. It's the lesion with abnormal connections that results in desaturation. Now, if you think about the mixing lesions, you could have obligate mixing, where the blood is forced into another chamber to mix because it has kind of nowhere to go, or non-obligate mixing, which is basically non-obstructive mixing. There's so big um, uh, the blood goes from the blue side to the red side, and there is no such cyanosis unless the desaturated blood is forced to mix via hole due to elevated PVR or poor ventricular compliance. And I'll talk you through examples of each of these. Once you have the obligate mixing could be either because it's non-obstructive, meaning there is a very large hole, everything is dumped into a common chamber, so mixing has to occur. Higher the PVR, the bluer you'll be. Lower the PVR, the pinker the baby will be. And in general, these lesions, because the hole is so big that they don't require a PFO or PDA for mixing. And then the obstructive lesions can either be a right-sided obstruction or a left-sided obstruction. If you have a right-sided obstruction, you basically need you need a PFO, an ASD, or a VSD that allows systemic blood to return to the body. And then you need a PDA to get the blood to the lungs. And under left-sided obstruction over here, you need the PFO, ASD, or VSD that allows the pulmonary blood to return to the body. And then you need a PDA to get the blood to the body. So with that in place, I know this is a dense slide, and I know I kind of just walked you through it. I'm going to step into the next step where I kind of go into how each of those categories creates these three major physiologies, so to say, of cyanosis. You'll be talking about these type of physiologies in many cardiac conversations, including the CICU. What we call the single ventricle physiology, what we call a VSD physiology, and what we call a transposition physiology. This grouping is a little bit too simplistic, so to say, but it meets the purpose of helping you create a framework in your head when you are talking about a certain lesion and sticking into a category, one of these three, which will help you explain the clinical findings on that patient and required saturations and things like that. So the TGA physiology, that is easy. That was the only non-mixing lesion. Your connections are abnormal, and there is separate blue and red, but going to the wrong side. Then you have these non-obstructive lesions where basically everything is either dumped into a common chamber or blood makes its way from left to right without any, so primarily does not result in cyanosis unless the PVR is high. Those will be the VSD physiology type. And VSD physiology by itself is not considered cyanosis. You don't think of a VSD as a cyanotic lesion, but in the setting of high PVR, this becomes a cyanotic lesion. And then finally, are true cyanotic lesions due to obstruction, either right side or left side, that result in a single ventricle type of physiology where the blood either to the lungs or the body is dependent on the patent ductus arteriosus. So VSD physiology, like I said, is really a subgroup of left to right shunting, which may be subtyped into pre-tricuspid shunt. So that basically means anomalous pulmonary veins or atrial defects, and post-tricuspid shunts, the ventricular and arterial defects. And knowing and understanding that anything that is a left to right shunt can reverse to become a right to left shunt if there is any type of um, obstruction distal to the defect. It could be either anatomic, like stenosis, or dynamic, like resistance. And then single ventricle physiology can be subtyped into ductal dependent pulmonary flow or ductal dependent systemic flow. So again, in addition to the basic lesion, always look at the rest of the anatomy for obstruction, additive lesions, and the ratio of PVR and SVR. So now here is a final slide. You have looked through the anatomy, you have looked through the physiology, and now you are coming down to what this is. What is the actual anatomy and physiology, and what can you do? So let's start again at the very beginning. I'm going to take TGA out. First of all, it's a non-mixing lesion. The patient is desaturated. You diagnose TGA on echo, and if there is an intact septum with absolutely no mixing, that baby will not make it because the blue blood is going back to the body and the red blood is going back to the lungs. You need to make the blood mix. So first thing that you can do is always start prostaglandins. Maybe some mixing happens across the PDA. But the big thing that needs to be done for these babies who are extremely desaturated is to very quickly get them to a cardiac center where they can undergo a BAS or a balloon atrial septostomy, where they open up the atrial septum, essentially pop it open so that mixing can happen, and some oxygenated blood makes it to the body. Then amongst the mixing lesions, really if you look at these non-obstructive lesions in between, which are either the total anomalous pulmonary venous return, which is unobstructed, or the single atrium, the single ventricle, or the truncus, or the ASD, VSDs, PDAs, tetralogy, that is non-obstructive with no pulmonary obstruction, or the Epstein's anomaly with good pulmonary outflow. These are non-obstructive and you basically manage them as a VSD. And then here are your obstructive or critical obligate mixers with right-sided obstruction. Let's think of every single obstruction that can happen on the right side of the heart. Cor triatriatum dexter, tricuspid atresia, pulmonary atresia, tetralogy of Fallot with pulmonary stenosis, Epstein's anomaly. In these cases, you are going to need prostaglandins so that the PDA can get blood to the lungs. On the other side, with left-sided obstruction, things like total anomalous pulmonary venous return that is obstructed, cor triatriatum sinister, mitral atresia, aortic atresia, coarctation, you are going to need prostaglandins so that the PDA can stay open and supply blood to the body. So here is an example of a lesion that we will be doing in our interactive class when we do it next week. And I just wanted to show you an example of how I want you to approach every box diagram that will be provided to you. So as you look at this picture, you have to start drawing arrows in the right color. So you can see that these are systemic veins, so it should be blue blood. This blue blood should come through the right atrium to the tricuspid valve. But as you can see, there is a membrane here. There is a cor triatriatum dexter. But as you can see, there's a hole here in the atrial septum. So the blue blood makes its way across the PFO and goes to the left side. Now this oxygenated blood, which was red, 100% oxygenated, mixes with the blue, and now you have purple blood going out to the body. And you can see that since nothing is going across the right side of the heart, blood flow to the lungs is dependent on the ratio of PVR to SVR. Blood is going to come here and then decide, do I go here or do I go here? And depending on the path of least resistance, it will go either to the lungs or to the body. So in this patient with core triatriatum dexter, this is going to be a desaturated patient for sure. Now you have to remember, more the pulmonary blood flow, more blood will go to the lungs, more oxygenated blood will come back into the left atrium, and then higher will be the saturation down below to the body. So the oxygen saturation will depend on the PVR and also upon how much pulmonary blood flow eventually makes it back. So with this example, I am going to stop here. The remaining slides are also individual lesions. What I would like you to do is for you to go through those slides and walk yourself through a few examples and see if you feel comfortable understanding the path of blood flow, the color of the arrows that have been used, and coming up with a diagnosis based on what these diagrams look like. Please reach out if you have any more questions, and we will see you soon in the talk.